let's get started. So I'm Dr. Comley. I'm from the CMH Department of Family Medicine. I've been given the opportunity to speak about epilepsy today. Obviously, it can be a pretty concerning, scary pathology to encounter, especially with the generalized tonic-clonic seizures. But let's go through this process today and see what we can find out. All right. So basically, we're going to start with the definitions, go through the epilepsy seizure types, the diagnosis, our considerations for the diagnosis, the guidelines, a few extra considerations, and then we'll come up with our conclusions. So why is it important to know about epilepsy? Well, 50 million people are affected globally. 80% of those people are in low and middle income countries. Within those low and middle income countries, 75%, that's 75% are not treated adequately. There's a 3 times higher risk of premature death in epilepsy sufferers than the general population. In South Africa, the prevalence can be between 0.5% and 1%, and with the correct treatment, up to 70% could live seizure-free. So that's quite an impressive number of numbers to look at, and it shows us why we need to really focus in on and pay attention to epilepsy. So some of the sources that I used here, so there's the South African Standard Treatment Guidelines. There's recently been an update on the neurological disorders chapter. So while it's not published as such yet, there's been an update, which is quite a good thing to look through. There's the International League Against Epilepsy, which is one of the big bodies dealing with a lot of the epilepsy aspects. There's the Epilepsy Foundation, and I've looked through up to date for a few other aspects. So the International League Against Epilepsy, I think this is really cool. I think there's the European League Against Rheumatoid Arthritis, and then there's the International League Against Epilepsy. So this is probably more what they look like. But I asked AI to give us a bit of a picture, and it looks like we've got some superheroes that are helping out. Although I'm worried that they're fighting brains themselves. But this is what I think the league would look like. Okay, so let's get started with the definitions. So firstly, actually, hold on. Let's do section 0.5 while everyone's awake. There's 2 very important things that we need to go through today, okay? Women of childbearing age, our approach to that population, and status epilepticus. These are some things that we really need to focus on. So let's start with women of childbearing age. So the things that we need to consider amongst this population group are the effects of the medications, the pregnancy desires, the control of epilepsy and how to best achieve that, and the differential diagnosis for what the seizures could be. So with regards to the medications, so it comes up again and again. It's almost 2 pages worth of things. Bottom line is valproate must not be used in pregnant women. I hadn't been fully aware of the statistics before. I'd always known it's contraindicated or huge cautions in pregnancy. But there's an 11% risk of a major birth defect in children born to women using valproate, and possible neurodevelopmental problems in between 30 to 40%. So these are huge numbers, and obviously something we really need to be aware of and use it in all of our management and considerations with this population group. If a patient is on valproate and discover that they are pregnant, then they should be transitioned to levetiracetam as soon as possible. But, and they emphasize this, don't stop the treatment abruptly, because there's an increased seizure risk, and increased seizures within pregnancy poses the biggest threat to mom and to baby. So this is not like a reflex, something that we should be doing. We should be considering this right from the beginning. So we need to consider our whole timeline of women that are not yet childbearing or are childbearing age, etc. So when we're starting anyone on an anti-epileptic, firstly, the guidelines suggest more frequently lamotrigine, levetiracetam, or carbamazepine. But here you always want to kind of consider starting with the lowest risk anti-seizure medication. And this would be lamotrigine or levetiracetam. And we'll speak a bit more about the differentiations between the 2 later on. And just in that picture there, you can see the kind of the spectrum, the degree of risk amongst the different anti-epileptics, the anti-seizure medications. Then with pregnancy desires, so here the concern with the medication as well as with the choice of contraception comes in. So we need to counsel on contraception and family planning. We need to speak about the preferred contraceptive. So for the medication, the preferred ones are the progestin-only injectables, such as Depo-Provera, and the intrauterine copper device. Control of seizures in pregnancy, there's considerations that are beyond just the medications that we're using. There are a lot of physiological changes that occur during pregnancy. There's also, and I'm sure some of us have encountered this, there's sleep deprivation, there's emotional stress, there's changes in your drug concentrations because of different metabolism, your plasma concentration is changing. And also there's actually change of your metabolism of your lamotrigine and your renal clearance of levetiracetam, and you may actually need to increase the dose during epilepsy, and this is why it's so important to keep monitoring it. Obviously, eclampsia. We need to have a very low index of suspicion for something like eclampsia occurring in pregnancy. And this is why it's important in terms of a holistic factor to make sure that patients are aware of the risk factors that could occur, and we're going to be monitoring them all the way through for any signs of eclampsia developing. The management is a bit different and needs to happen fast, considering mom and baby. Okay, so you're always worried about status epilepticus.